I'm going to talk to you about plaster of Paris, which is the external fixator just before external fixation. And I'm going to talk about conservative treatment because there is a role for conservative treatment. If you're going to apply a fixator, you have to be able to reduce the fracture. So, and reduce it closed. I'm going to show you how to do that. The anatomy of the ankle joint is key to successful closed reduction of malleolar fractures. The ligamentous system around the ankle allows for ligament ataxis and passive movement of fracture fragments into anatomic positions. Now, the classification, two widely used classifications, the AO or Weber classification versus the Lager-Hansen classification. These are actually the same classifications, except one is an anatomic classification, which is the AO, and the Lager-Hansen classification is a mechanism classification. So here's the AO classification. You're all familiar with this. Sorry. And if you look on the top, you have the Weber or AO classification, and on the bottom you have the Lager-Hansen classification, and you see that the supination adduction injury is the equivalent of the Weber A. The supination external rotation, stages 1 through 4, or the pronation abduction, stages 1 through 3, give you a fracture pattern that's identical to what you see with the Weber B. And the pronation external rotation, stages 1 to 4, give you a Weber C. So in fact, these are the same fracture classifications, just a little more, as I pointed out. One is an anatomic designation, and the other is a mechanism of injury designation, but in fact, they're describing the same kind of fractures. So the management of these, many of these can be managed without surgery, but this is time-consuming for the patient and the surgeon. So unless you have the patience to manage these people with this kind of fracture, you are not going to be happy, and they're not going to be happy. But many patients will not want an operation or are not suitable for operation, and they have to be managed without surgery. So what are the indications? Well, the number one indication around the world is a lack of resource for surgical treatment. So the great majority of ankle fractures and tibia fractures sustained throughout the world are treated without surgery. And we forget that sometimes working in these great big hospitals where we operate on everybody. But in fact, there's a lot of places where wasting a valuable resource on an ankle fracture wouldn't even be considered for a minute. Fractures with minimal displacement don't require surgery. Stable fractures. Many elderly patients are poor candidates for surgery because of poor skin quality and poor bone quality. Stefan's already talked about the problems of diabetes and fracture healing and skin management. And of course, people with peripheral vascular disease, people who smoke. Now, in order to do this successfully, you have to be able to do a closed reduction of the ankle. And the way to do this is to, first of all, have a properly anesthetized or sedated patient. And by lifting the foot up like this by the toes and having the knee roll out, the hip roll out into external rotation so that you're putting a varus force on the ankle, you can reduce these fractures quite effectively. And this shows the same thing. You have the patient's foot, leg externally rotated, and you're supporting their foot below the ankle on the lateral aspect of the heel. And this will reduce the subluxed or dislocated talus back under the tibia. You have to, when you're reducing these fractures, it's a mistake to push the foot up into neutral or a plantigrade position, because all you do is push the talus back behind the tibia again. What you have to do is lift the foot up so that the talus comes to lie under the tibia, and this will satisfactorily reduce the fracture. And this is a mechanism that you can try in the operating room. If it's unclear to you when I'm talking to you about this, just give it a try in the operating room and you can see how that fixes the fracture. And then applying the cast, you have to have the cast well molded. And you'll notice that the One hand is molding the plaster proximal to the fracture, and the second hand is molding the plaster distal to the fracture. You're not pushing on the fracture, you're pushing above and below the fracture in order to keep the foot properly aligned. So this is an example of that. If you're molding uniformly, you don't do anything for the fracture displacement, but if you mold proximally here and distally there, the fibular fracture will reduce. So a well-molded short or long leg cast, I prefer short cast. Most patients don't need a long leg cast. Non-weight bearing for 4 weeks. This makes it awkward for some patients. And then you convert the initial cast to a weight-bearing short leg cast or an air cast splint or removable splint, progressive weight bearing, and then a removable splint for range of motion of the ankle and the subtalar joint. So at 10 weeks, external splintage is necessary. People doing heavy physical activity, otherwise they don't need anything, and they do need a formal exercise program, but they can do this at home. They don't have to go to a physiotherapist to have this program. Stable fractures, like an isolated medial malleolus fracture, I let them weight bear immediately in a below knee cast, 4 weeks of removable splint with active physio, and by 8 weeks they don't require anything further. And here's an example of a vertical undisplaced medial malleolar fracture. That would frequently be operated on in our hospital. This patient wasn't terribly interested in having an operation. He was an insulin-dependent diabetic, young, active person. So he was treated in a cast, and there's the healed fracture, satisfactory outcome. So I sometimes show these x-rays to the residents in our hospital who rarely see fractures treated without surgery, and they're quite amazed that a fracture can heal without an operation. Now, isolated lateral malleolus or Weber A, I treat them exactly the same way. And they have substantial non-union rate, those little tiny avulsion fractures of the tip of the fibula. They have a 50-60% non-union rate, but they're uniformly asymptomatic. Now, the Weber B fracture, you have to assess the medial clear space. Less than 5 millimeters of clear space is a stable fracture, and you can treat it just like a Weber A. Greater than 5 millimeters of clear space, with or without a stress test, it's like an unstable bimalleolar low velocity fracture. In other words, there is a potential for it to be unstable. It requires a little more attention to detail, but does not, by virtue of having that bit of clear space, does not necessarily require surgery. So here's an example. You can see there's a fibular fracture here, minimally displaced, but it's increase in the medial clear space. Operate or don't operate. There's the mortise view. Now, the most important view here, of course, is the lateral view, which shows that the talus is squarely under the tibia. So this suggests that this is not a particularly unstable fracture. You can see the fibular fracture in that area. So here's the plaster applied, and you can see that we have the molding distal here, proximal there. You can see how we've molded this. The clear space is closed up very nicely. It's equal all the way around the talus now, and the fibular fracture is in good position. The mortise view, the lateral view. And so we continue like this, non-weight bearing, for 3 to 4 weeks. And then we convert them to a weight bearing cast, and then this is the outcome. You can see they have a normal ankle joint. There's a weight bearing x-ray, good maintenance of joint space, healed fracture, and I can assure you satisfactory function, and quite happy not to have had an operation. Here's another one, a little more controversial perhaps. High fibula fracture here, some medial tenderness, slight tendency towards opening of the medial clear space. There's the mortise view. Again, we treat this exactly the same way. Well molded cast, you can see the molding here. Okay, lots of molding above the ankle, lots of molding below the ankle, to provide that. You have to advance these slides because, or turn off the timer, one or the other. So here we are, healed fracture. Now, a fracture displacement that occurs during closed treatment requires open treatment. I don't believe in doing repeated closed reductions. Here's an example of an unstable ankle fracture in an elderly woman that did not want surgery. I thought she should have an operation, but she did not want surgery. And there you can see she has a fracture dislocation of her ankle with a large posterior malleolus. This fracture is not a suitable fracture for conservative treatment. Here's the closed reduction. So you see we have quite a satisfactory reduction, but because of the instability of the fracture, this is not going to be successful. And sure enough, in the cast, this redisplaced in a short period of time. So what are the results of this type of treatment? Well, if you have medial malleolar fracture and you treat them conservatively, there's about a 10% non-union rate. These are almost universally asymptomatic. They tend to have a slightly stiff ankle compared to the opposite side and a stiff subtalar joint compared to the opposite side, but very little or no functional deficit. And early weight bearing will decrease those complications, so the faster you let them walk, the less problem they'll have with their ankle. So here's a good paper for people to read, I think. This is from the Canadian Orthopedic Trauma Society, a well-recognized group that does large randomized trials in our country. And they enrolled a significant number of patients, about 150 patients, into operative versus non-operative treatment of unstable Weber B fractures, okay? So that half of them were operated on and half of them were treated, as I've just shown you. And this is a direct quote from the paper, there was no statistically significant difference between those treated operatively or non-operatively. So the indication for surgery in these lateral malleolar fractures is, I think, largely overstated. Now, I'll spend 2 minutes on tibial shaft fractures. Many of you in the room treat tibial shaft fractures conservatively, I'm sure, depending on your hospital and where you work. Basically, fractures of the tibial diaphysis that are 100% displaced are unstable. In other words, high velocity fractures or open fractures require surgical treatment. So that's the end of that discussion. We're not talking about people who've been hit by a car at 60 kilometers an hour and have an extensively comminuted fracture. We're not talking about that. We're talking about the stable, low velocity, slip and fall type of tibial fracture. So those that are less than 100% displaced and are potentially stable or closed can have non-surgical management. And the non-surgical indications are exactly the same as for ankle fractures. Now, the steps for success, how do you make this work? Well, the immediate treatment is by closed reduction if necessary, rarely is necessary. You put them in a long leg cast with the knee in extension, and you get them walking as soon as they can put weight on their leg. So immediate weight bearing in the long leg cast with their knee in extension. They need some x-rays, then at 2 weeks, you change the long leg cast for a patellar tendon bearing cast. And it's funny, I saw a guy on the street, we were coming to the meeting today, walking along in a PTB cast. He was making pretty good progress, actually. So these are well molded at the proximal tibia to control rotation, a plantigrade foot, and you have to keep them weight bearing, okay? The key to success in closed treatment of the tibia is functional treatment, okay? Sarmiento's treatment, and so they have to be weight bearing. And you x-ray them every couple of weeks to make sure the fracture is healing. So at 6 to 8 weeks, you can change the cast. You can continue with the PTB if you're in a resource depleted area, or you can switch them to a fracture brace, which is more expensive. If they're in a fracture brace, they can come out for their exercise, but otherwise, they continue weight bearing as tolerated in a PTB cast. At 12 to 14 weeks, 90% of these fractures will be healed. You assess them for healing by stressing the fracture, seeing if they have pain on weight bearing, and an x-ray. Physiotherapy is a good idea to improve range of motion of their ankle and subtalar joint and avoid contact or high-stress sports or high-stress work for 24 weeks. So what are the pitfalls in closed treatment? If you have an intact fibula and a slightly unstable tibia, the intact fibula can cause delayed union or cause a varus malunion of the fracture. And in segmental fractures, the proximal fracture will heal first. The distal fracture may well have delayed healing, and this is an indication for surgery often in segmental tibial fractures. So many low velocity tibial fractures can be treated without surgery, but you have to remember as much skill is required in the management of these fractures by closed treatment as is required in the management by open treatment. So if you don't know how to treat them closed, don't think that you're going to be successful. Just like if you don't know how to treat them with surgery, you're going to be successful. It requires just as much skill, just as much attention to detail. So remember, if you're going to treat these fractures non-operatively, tibia or ankle, you need the right patient, the right fracture, but most importantly, the right surgeon. Thank you.